Okay, so let's start. Voice and speech-based marker of neuropsychiatric condition. This is the title of the talk, and the main topic is the so-called speech marker. I will try to give a brief introduction. This is the agenda, so I will start to introduce what do we mean with the term speech markers, and also I will try to summarize what is the state of the art in the field, and also what was our contribution in the last 3-4 years. And then I will try to sketch what are the open problems in the field, how we can start to tackle the problem with some preliminary ideas. And then I will move to the SEED project. It's focused on the Danish and high risk and resilience study, in particular on a speech corpus coming from the YS7 studies. And after that, I think it will be over. So let's start from speech and mental health. Why speech and language are related to mental health? Because speech and language are a very highly sensitive signal. So even small changes in the speaker emotional, cognitive, or physiological state is generally reflecting in a characteristic speech and voice pattern. And because of this association between physiological and cognitive mechanism and speech production, we can also use voice and speech analysis to get information from clinical condition. For example, in Parkinson, the motor disorder associated with Parkinson are reflected also in a very characteristic voice pattern that we can measure to have information also on the symptoms related to voice disorder. And it's the same, for example, in neuropsychiatric disorder. In schizophrenia, we have negative symptoms, and these symptoms are really reflected in a characteristic flat vocal pattern, which can help us to track the symptoms or have information on the development of the disorder over time. And there are other advantages of automated language and speech analysis. For example, the fact that it's automated, that is scalable to large corpora, is potentially cost-effective, is quantitative. We can use, for example, mobile device to collect audio recording in a real-life setting. And these are all reasons that explain why voice and speech analysis can be potentially used to monitor the symptom, the progression of the disorder, to help the clinician to make the diagnosis, to develop what is called a digital phenotyping, and also offer a more fine-grained perspective of the social function, for example, or the social characteristic of this disorder. This is what the papers are showcasing in the literature, and this is not a new idea. These are some references from a paper from the 60s that I encountered when I started to make a meta-analysis in the field. And in the 60s, this paper were basically proposing the same idea. So the fact that we can use this, in that case, was this very old technology to track negative symptoms of schizophrenia and to develop marker of this symptom. And this is just to say that this is not a new idea. So this field started more than 60 years ago, and even if we have very huge potentiality and we had a very incredible technological boost, we have not yet effective clinical applications. So effective clinical applications are still missing. And this is what I found out when I did a meta-analysis with Ricardo in 2017. So the idea was to, of course, provide a complete overview of the previous finding of the literature, but I would say that the most important aim of the review and the meta-analysis was to lay the ground for future work. So we wanted to identify which were the open problems, the current practices. We also assessed, for example, the availability of authors to share the data, potential issue, methodological aspects, and so on and so forth. And in the meta-analysis, we found a characteristic voice pattern associated with schizophrenia. For example, we found patients generally speak less or reduce the speech percentage. They have also a slower speech rate. They produce less words for each minute they control. They produce longer pauses. They have reduced speech variability. And all these features were associated with characteristic symptoms. But we also found many problems. We found publication bias for most of the acoustic and NLP features. We found large heterogeneity, so the generalizability of this result has yet to be assessed. We found a lack of systematic approach, a lack of theory-driven approach, very different methods, very different pipeline, very different statistical analysis. So it was very difficult to compare the result and get an overall picture from this literature. But the two most important problems were these two. The cross-linguistic generalizability of previous result had not been assessed, so there were no cross-linguistic study. There was this assumption that we should expect a universal vocal and language profile associated with schizophrenia, because schizophrenia has similar biological mechanism, underlying biological mechanism, but we know that really speech and language map into the specific language spoken by patients, and so this was one of the problems we found in meta-analysis, and the other was the heterogeneity. So we know that neuropsychiatric disorder and schizophrenia are really heterogeneous in terms of symptoms, pharmacotherapy, clinical and social characteristics, but this heterogeneity was rarely assessed in the previous study. Most of the studies were monolingual with very homogeneous sample of patients with very similar characteristics. And this, in our view, was a problem. And so I would say, after the meta-analysis, we ended up with more doubts and questions than with established findings. So we found what I used to call dark side of speech markers, so the fact that even if all the papers were showcasing the potentiality of this technology, in fact, despite expectation and the fact that papers were really saying that these applications were enhanced, in fact, we have no concrete clinical application because of this problem, because we don't know if these results generalize well across samples, speech tasks, languages. We don't know if these results are robust and which are the effect of using different methodological choices. We don't know which are feasible clinical applications. So we started to make some work in the field. We collected this large, we built this large cross-linguistic corpora of audio recording of patients and controls in 4 languages: Danish, German, Chinese, and Japanese. And relying on the suggestion that we did in the meta-analysis, we tried to do better. We tried to improve the field a bit. So we used this setting, this corpus, to test whether results from the meta-analysis generalize well across the different sample of our corpus in the different languages. Also try to account explicitly for the heterogeneity. So, for example, we assessed the association with demographic, clinical features, pharmacology, and social features. And these are the results in brief. So for the voice, we found just one feature replicated well in all the corpora, this speech variability, reduced the speech variability, the flatter tone of voice of patients, while for all the other features, we found very limited replicability or no replicability at all. For example, speech percentage, there were one of the most large effect size in the meta-analysis, were not replicated in any of the 4 samples, in any of the 4 languages. While for the other features, we found replication in 1 or 2 samples at best. So replication was failed. And the same was for NLP. So we also implemented an NLP pipeline. In this case, we measured what is called semantic coherence. That is a measure of how disorganized or illogical is the speech of a patient with schizophrenia. And this incoherence, semantic incoherence, also taps in some specific symptoms like illogicality or incoherence. And again, we found very similar features. So only one, what is called coherence, second order coherence, replicated well. In this case, we were 3 corpora, while for all the other features, we found just replication in the Chinese corpus. And this is, so we thought that maybe it was because we were focusing on a univariate model on single features, but we know that both for NLP and voice features, there are complex multivariate pattern and interaction between the different features. So we try to use machine learning and to use classifier using this large set of acoustic and NLP features, in this case it was acoustic, for predict the diagnosis of patients versus control. And the results were similar. So again, when we trained a machine learning, a voice-based machine learning model in a specific language or in a specific corpus, like the Danish one, and we test of new participants from the same corpus, the accuracy, the performance of the classifier was generally good, at least comparable to the state of the art, between 70 and 90%. And when we try to test the generalizability of a model in different language or in different sample, the performance dropped to the chance level, so it was very, very crappy. And so the take-home message was that we had to face a problem of generalization of results. We found large discrepancies with the result of the meta-analysis, very limited replication, large differences across our different corpora. And there are many potential reasons. The fact that these disorders are really heterogeneous, so it's not so surprising that when we try to predict, we try to apply model to a more varied and large sample, the performance tends to drop. We've also found heterogeneity of methods in literature. As I said in the meta-analysis, we showed that there were so many methods, so it's not different methods for the acoustic and NLP pipeline, for the analysis, so it's not surprising that the replicability was low. And then there were also other reasons, the small sample size of previous studies, no mechanistic or theory-driven explanation. So what was missing were large-scale candidate selection studies. And all these, I would say that these reflections and this problem were discussed in two occasions. One was a consensus workshop held in Leiden in last November, and that also ended up in a paper, consensus paper, and a seminar here at Interactive Mind last December. And the question inspiring this workshop and seminar were, what do we need to advance the field and to implement a speech marker-based clinical decision support system? What is missing? And so the aim was to identify potential clinical application and goals that we can pursue to reach the aim of clinical applicability. And these were some of the most, I would say, important urgent needs. For example, the need for large and diverse open dataset, representative of the entire schizophrenia, the variability of the schizophrenia spectrum, of the neuropsychiatric disorder spectrum. This dataset to be used as a benchmark for validation of NLP and voice pipeline, and the need for some kind of informed open modeling pipeline, such a way to homogenize a bit the methodology to extract the data and to ensure comparability. Also, another problem was the bias in the sample selection. We have selection bias. The patients that are included in the study are really a specific category, often, again, not representative of all the spectrum. And then we also discussed about ethical issues and the fact that the goals of most of research is not really matching the clinicians and patients' needs. So, for example, most of the paper are focused on binary classification, but this is not really a helpful task because we are just mimicking trying to predict the diagnosis that we already know. And one of the things would be that we maybe should focus more on a dimensional approach. We should focus more on the symptoms and on the underlying dimension of the psychopathology more than just trying to predict diagnosis. And also to adopt more holistic explanation, mechanistic explanation. And one way for tackling these issues, for example, the issues of binary classification, of heterogeneity, is, for example, to look at developmental trajectory. And this is a very long introduction to get to the point of the early signs of mental disorders, to the fact that basically this is the phases of psychosis. So we have the onset that is around 18 and 25 years. And after the onset, we have this acute phase, then we have recovery, but most of the time the intervention after the onset are really not so helpful, so are not so impactful. But there are a lot of things going on before the onset, starting in childhood and continuing in adolescence, so we have a lot of programs. But basically most of the studies are focused, I would say 90% of the literature is focused on studying schizophrenia or neuropsychiatric disorder after the onset. With very few focusing on predicting the onset, but very, very, very few focusing on childhood and adolescence. And schizophrenia and also, for example, bipolar disorder are considered neurodevelopmental disorder, so there is a strong role of genetic and environmental factors. And so the knowledge of the etiology and the developmental disease is very, very limited because of the fact that we have very few studies but it's very crucial for implementing prevention strategy and also identify individuals at high clinical risk. They are even more important because we know that intervention after the onset are not so helpful and impactful, despite a huge amount of money and research spent on it. And the problems, so the phases before the onset are really important because it can also allow us to identify the vulnerability factors, so the psychopathology, the cognition, the motor and social abnormalities that appear usually much earlier than the onset. So these are windows into the healthy pathology and pathophysiology of the disorder. And this is the reason that motivating the Danish High Risk and Resilience Study, VIA7, that is a large prospective cohort study, including 522 children with one or two biological parents with schizophrenia or bipolar disorder or no diagnosis of neuropsychiatric disorder, 202 with familial high risk for schizophrenia, 120 with risk for bipolar disorder, and 200 population based on control. And so this is a longitudinal study. The children are assessed and the parents are assessed when the children are 7 years old, then again when they are 11, and then again when they are 15. And we are now at the last stage. So the collection of data when the non-children are 15 years old in the start of the adolescence. So we are almost at the end of the project. And also large comprehensive assessment battery have been assessed, including biological data from the non-analysis screening with biobank, behavioral data, assessing cognition, social functioning, emotion, home environment, daily functioning, distress. So very, very huge amount of data, very rich assessment to try to disentangle the developmental trajectory. And basically, there is also a speech corpus coming from this study. And this speech corpus is what we focused on, and it's basically on this corpus. The SEED project is based on this corpus, and the also analysis that we are trying to do. And our main question were, so can we use machine learning approach to language analysis, so NLP and voice analysis, to in a diagnostic and prognostic fashion to identify and monitor the development of clinical symptoms in children with high clinical risk. So we can leverage on this corpus to try to tackle questions that are related to the early signs of the disorders and how we can tackle the heterogeneity associated with the mental disorders, with neuropsychiatric condition. For example, can we do better in predicting clinical feature and social outcome if we adopt a dimensional approach on this data instead of looking only at the patient's diagnosis, in this case also the parent diagnosis. And the clinical utility, how we can track the developmental trajectory of these symptoms and also the related voice and language typicalities, and how these, having information on the developmental trajectory can inform a more mechanistic or at least more holistic explanation of the disorder. So how can inform the development of speech biomarker, for example, developing normative model or identify the most predictive features. And so these are the people included in the SEED. There is Matthias Andersen, this is a research assistant, Lasse, Kenneth, Roberta, me, and Ricardo. And a very, I would say, a very long introduction because we have not yet results. But what we have did with the SEED money is basically to make all the manual transcription and the speech preprocessing and the cleaning, noise removal. So this is the corpus, the language corpus from the VIA study, which include two different tasks. The 5-minute speech sample task, that is a task in which parents have to produce a 5 minutes description, autobiographical description, in this case of their children. And this is a task that is generally used to measure the expression of emotions. And then we have also the animated triangle task that was performed both by the parents and the children. And these are the data that we have assessed until now, and we are also pre-processed. So we have 142 subjects for the animated triangle task and 155 subjects for the 5-minute speech sample task. We have also some clinical data, and what we have done so far is all the pre-processing. We have transcribed all the data. We have the annotation, the decoding, the diarization, and the manual noise removal. So the data are now ready for developing a proper pipeline and to be analyzed. And of course, this took a lot of time. But okay, a tentative data analysis pipeline. So we have some preliminary ideas on how to analyze this data, and this is something that we will do in the next months. So the first things would be that we have NLP and voice-based machine learning models that we have developed in previous research on adults. And so the first thing would be to test whether these models generalize well if we test on this corpus. So, for example, do the models work well on parents with mental disorder from this corpus? Of course, these this case, the parents with a neuropsychiatric disorder have different characteristics compared to the patients that are usually included in the study because they have kids, they generally work. So it's a very different characteristic profile compared to the studies that are enrolled in research on schizophrenia. So this would be a test of generalizability of results. And then we can also ask, do they work on children? If we apply the same machine learning models and we apply on children, we know that, of course, that, for example, the voice features or also language features could be very different. And we could ask what are the speech features most predictive. So if we apply the same model, would be this model able to predict schizophrenia just, for example, in children which have a parents with a diagnosis of a mental disorder, or there are specific acoustic features that could boost the prediction. And then we could think about training new models, so based on clinical relevant features, or theoretically based, we can try to develop new model on this corpus, specifically on this corpus, and to test them, for example, in adults to predict diagnosis, or in the children to predict the prognosis, or, for example, later onset or development of more severe symptoms, having longitudinal data. So we have a basic, the temporal dimension, that is something that is new, that is not generally present in previous studies. And we have also these comprehensive assessments, so potentially, we have not yet access to all the data, of course, but potentially it could be used to build more complex models which integrate also social information and environmental data, and that could help the prediction and to sketch better the developmental trajectories that can lead to the development of psychiatric disorder or psychotic disorder. Can we do better? Maybe you can help. So comments are very welcome, and also critics are welcome too. And thanks a lot to the SID for helping us with all the cleaning and the project. Thank you.